on December 8th, Thursday, December the 8th, 10 a.m. I think December the 8th also marks a landmark event where about 14 organizations have committed to the inequalities plan, which include Northumberland County Council as well. And it's a real great step forward. I think this is the beginning of a 3-year journey in our struggle against inequalities. And also, today also marks a second milestone event, which I would reserve it till the end for the maximum impact. Okay, so I'll come back just before any other business. Okay, so to start with, any apologies for absence?
Yes, there's apologies from Julie Boyack, Neil Bradley, Jackie Daniel, Paula Mead, Councillor Renna Thompson, Councillor Simpson, and Claire Wheatley.
Thank you. Thank you, Leslie. Minutes, are there any comments on the minutes of the last meeting held on Thursday, 10th November 2022? If there are no objections, I will sign those minutes as a true record of that meeting. Thank you. Disclosures of interest. Any disclosure? Okay, thank you very much. Move on. So that allows us to come to one of the first main events, a presentation by Kerry Lynch on tobacco control. Okay, all the best.
Thanks very much. My name is Kerry Lynch. I'm Senior Public Health Manager here at the Council. I lead on tobacco control in Liz's team. Hopefully you've had a chance to have a little glance over the report that I've written. There's a lot of information in it. And the reason for that is that, like so many public health topics, tobacco control is complex, it's multidisciplinary, it's multi-agency. And because of that, I wanted to come and speak to you today about where we're up to with that kind of collaborative approach to addressing tobacco in Northumberland. I'll press the right button. I'll give you a little bit of background. I'm not going to go into a lot of detail. I know I've only got sort of 5 or 10 minutes, but I just wanted to highlight some of the background that I've got in the paper. Smoking prevalence is declining. It has been declining steadily over many years. You will know that we commissioned Fresh, which is the regional tobacco office. Regionally, we saw the biggest decline of all regions. Over kind of less than a 10-year period, and we've matched that in Northumberland, a 6.6% decline in smoking prevalence, like I say, in less than 10 years. And when the prevalence is looking sort of healthier like that, if you like, sort of around 12%, it's useful to then start to look at the numbers, because for a county of our size, 12% of people smoking is still thousands of people, 30-odd thousand. My maths is very rough. And we've got new prevalence figures out just this week, which is showing us at Northumberland at being 11.8%, so we're still declining. But it still means we've got thousands of people in our county suffering from the harmful effects, health and economic, of tobacco. And one of the key things I want to kind of run through everything that I say for the next 5 minutes is around health inequalities and how smoking drives those, exacerbates those. People who are already living with some kind of disadvantage or inequality are the ones who are more likely to smoke, they smoke more, and they also find it difficult to access the support that they need to stop. Once they get to that support, they have as much success as anybody else, but it's getting to it that's difficult for them. So people that are living in social housing, for example, people who have no qualifications or unemployed, or those who are employed in routine and manual occupations, are smoking at rates that we haven't seen in the general population for decades. So if somebody who's living in social housing, that group of people, there's 30% of them smoking, and it's unacceptable. We just need to keep moving. And what I want to ask you to consider and to steer the next phase of this work is what we need to focus on, which I would suggest are these sorts of pockets of our population. And if I can be so bold as to make that statement at the end of the slide, so to tackle poverty and health inequalities, which I know is a number one priority for you, we need sustained further work on tackling smoking, especially in those communities. Like I just mentioned, so the people that are affected the most by smoking are the ones that are already sort of dealing with disadvantage or an inequality. And I've lifted in the paper and kind of highlighted here on the slide for you. So, for example, pregnant women, of course we want pregnant women to not smoke or to give up smoking, but just highlighted in purple, smoking in pregnancy is 5 times more common in the most deprived groups compared to the least. People with serious mental illness, we can estimate that in Northumberland, people with serious mental illness, it's about 37% of that group smoking. And again, illicit tobacco. People access illicit tobacco for a whole range of reasons. One of them might be cost. 77% of those who buy illegal tobacco are from the 3 lowest social and economic groups in society. So these are just 3 examples of how it's affecting people that are, disproportionately affecting our poorest communities. I put in the paper some kind of key issues that I wanted you to give me some advice on. So one is, and I've put a lot in the paper about the latest happenings in terms of kind of national ambition, which was around Smoke Free 2030, an independent review that was commissioned, and some recommendations that were in that. I can't keep up with the pace. The political stage moves very quickly. However, it doesn't really matter whether these recommendations are the ones that a national government pick up or not. To me, doesn't really matter. The devil would be in that detail. What we definitely do need is a national statement, a new national statement on tobacco control, because this one will run out. The current plan runs out at the end of this month. So again, my ask in the paper was, can the Health and Wellbeing Board influence up over nationally, that national ambition? And if not, can you recommend how we do that in the council? So what the really important thing I wanted to bring, as well as some of that national picture and the figures, was to note all of the work that we've been doing in the council, but also with partners, and that they are also now leading on. I've given lots of examples in the paper of some of that work. The way that I've been leading the tobacco agenda for us in the council over the last couple of years has been sort of in a thematic way. I've been working with the Trust on Smoking and Pregnancy. I've been working with CNTW colleagues around mental health. We've got a good relationship going internally with Trading Standards, and a particular post there focusing on tobacco and alcohol. So I've been doing it in that way, and I think there's enough now, and there's a groundswell, and we've checked this out with stakeholders in the first sort of meeting that we've had, that it's time to come together as a collaborative partnership, as a more formal partnership now. All of again, I've put a slide in the paper, all of the people that we've spoken to have said, yes, if we come together, it means we don't reinvent the wheel, it means we don't duplicate the wheel, and certainly I don't want to do that, because all the organisations will have their own work happening on tobacco. What I want the new Northumberland Tobacco Partnership to do is the things that we can only do together, or the things that we're not currently doing. So certainly I want to give that assurance to those of you representing other partners. It's not about doing the same again. It'll be about trying to focus on some of the things that are different, or that we can only do together. So please note all of that progress. But also I'd like you to kind of endorse the development of the new partnership, and also advise me how we should best govern that, and whether we would come regularly to the board, for example. So again, that's for you to steer, and obviously I'll be steered by Liz and Councillor Patterson as well. If we can influence the national picture, and again, I've got a letter ready, drafted, that can be used to write to the Secretary of State. We can do any of that, and I can provide all of that information. But certainly just about trying to put a little bit of local pressure nationally on that national ambition and the national plan. And then another thing that we could do as a springboard for the new partnership is sign up to relevant declarations. There is a local government declaration on tobacco control. Northumberland County Council signed it in 2018. There's also an NHS smoke-free pledge. Both of those declarations have been updated this year to reflect the new ambitions, although, like I say, it's probably going out of date as I speak. But it would be good to kind of have that new leadership and endorsement, and it gives us that springboard as a partnership to act. You won't be able to read this, but this is the kind of contents of Kerry's brain to some degree, and also checked out with partners about things that they're doing around tobacco control. And we put it into these kind of, it's 8 themes because I've got 2 in together. And this was a snapshot a couple of months ago. What we've been doing since then is going out and speaking to all of these partners and trying to put a little bit of flesh on that. But like I said, then the next stage will be, okay, so which are the things that we need to do together that I would like to move the partnership towards? And like I say, in order for us to act, we know what we need to do. This is a really well evidenced, piece of work. The tobacco control evidence is coming out of our ears. It's an internationally recognised approach to do it in partnership and to do a multidisciplinary approach. World Health Organization, World Bank. But we would what it needs, one of those key strands, is leadership and commitment. So if we could do that by signing those declarations, that would be good. I'm very willing to come again and give you more detail about what those declarations are and what you'd be signing up to. But if we could just at least sort of say, yeah, that would be something we'd like to do, we can take that forward. So that's kind of it. I know it was a big paper, and I know I was asking quite a lot of things in it. But thank you. And if you could consider those recommendations around sort of national influence, endorsing the partnership, and also consider what you think we should actually focus on as a group in the next stage. I'll obviously given a few examples today, and clearly let me know if you want any more information on anything, and I can provide that for board. Thank you.
Thank you very much. Are there any questions for Kerry? Yes, Alistair?
Oh, we have to switch your thing on.
Great presentation, and really it's a very important issue really in terms of the health implication, the economic implications, everything. And you've got it there on your last slide. Where I think we need to lobby as well is that at the moment we've got a real disconnect between e-cigarettes, which are clearly either a route to coming off inhaled tobacco and cigarettes, or a risk modification in that swapping is better and a tool to come off is even better still. And yet one is purely there on a commercial basis, and there's no access for our public to e-cigarettes or anything like that on any of the smoking cessation courses, other than specifically through maternity, who've actually had some really promising results, I think, with that. And it's how do we start influencing national policy, because it strikes me that we're absolutely ignoring something that the public have captured. Yeah. And what we don't want to do is be subsidising people who are going out and buying their own vapes on a long-term basis, but people where they're trying to come off cigarettes. It would just seem that we're missing a real trick, and that's a national missed trick as well as a local.
Thank you. Can I respond? And absolutely, thank you. And it is, and it's a hot topic at the moment, because it depends on which lens you're looking through as to how you might feel about vaping. But as you've absolutely said, for an adult smoker, switching to an e-cigarette will offer a fraction of the risk, and it's definitely the thing to do. So the Trust are tromping ahead with lots of work around tobacco dependency, which is fantastic, which I've put some of those examples in the paper. And then also for the council of our community stop smoking service, we've received a grant from the ICS to pilot vaping with people with serious mental illness. So that's just getting off the ground at the moment. Wansbeck and West PCNs are involved, and we're going to roll it out to the others, actually. It won't give us big numbers of people coming through, because these are people with serious mental illness, and as I said at the beginning of the presentation, they have lots of barriers to get through before they can access that support. But once they do, we're going to pilot some of the vaping locally. But yeah, anything that we can, any sort of muscle that we can exercise up over to influence the national picture, that would be really helpful.
Thank you. Wendy?
Thank you very much, Chair. Kerry, thank you for this report. Your passion and commitment for stopping smoking really comes across, and so really appreciate this. What I wanted to say is, what do we do in schools? I think we need to nip it right in the bud from the start, and I just wondered what our programme was there.
Yeah, the thing with young people is that the evidence shows that if we change the adult world that young people grow up in, then they're less likely to smoke. So there isn't very many young people smoking now. It's kind of in single figures in terms of a percentage. And the more we do to change society, and it's becoming kind of less and less acceptable to smoke, that does have that influence with young people and in schools. So nothing specific and nothing around stop smoking from our point of view, but certainly in education, they'll be doing what they always do around health and well-being in schools. But actually, the evidence shows that the more we do with adults, that will make the difference. What I am getting a few questions about now is vaping with children and young people. But I think we just need to be careful. I mentioned that in the paper, that it feels like a lot. When you see a group of young people smoking, or now you see a group of young people vaping, it's noticeable, but it's a group of 6 or 7 of them. And actually it's still a small percentage. I've checked this out I have a 15-year-old at home, and I said to him, who's vaping? And he said, it's the year 7s. And I said to him, do you think it's the same children that would have been smoking? Do you think the ones that would have smoked are now vaping? And he said, yeah, it's the same sorts of, the same children that would have done that. So you're right to raise it, Wendy, but I think take some assurance that the multidisciplinary approach is what will make a difference to the young people as they grow up.
Thank you very much, Kerry.
Thank you.
Thank you. Graham, yes.
Yeah, thanks very much. I noted in the report that the fire service hadn't been at some of the initial meetings, but we are.
We've only had
now,
one,
yeah.
and we got some apologies, but you've been engaged before. So,
yeah, so we will be at that, and I think the important bit of this is, as a new member of this board, I presented on the collaborative approach, our collaborative approach to safety and well-being. Smoking synonymously for a fire and rescue service would have been to do with home safety.
Yeah.
But as we move into much more of a collaborative approach to the wider determinants of health and how we can influence and impact on that, there's a key role for us to play, not only in keeping people safer from fire in their home, but also understanding the links with smoking, alcohol, dementia, and deprivation. So we are fully committed to be in and around that agenda.
Perfect.
Thank you.
Thank you very much.
Yes, Jeff.
Thank you, Chair. I just wondered, really a question to Rob. Illicit, illegal tobacco, presumably that's part of our public protection service. Do we? Yeah. Can you give us an idea of how big a problem we've got and how many prosecutions we get? Or?
We do prosecute and we prosecute successfully, and we budget very much into criminal activity and its effect on health. I know the figures in front of me, but I can get you a breakdown of the amount of prosecutions that we've done. But we always try and put them in the press when we do them, so people get the message that it isn't a victimless crime.
Yeah, and Chair, if I can just add as well.
Please.
So we're working really closely with Trading Standards at the moment. We've got a post that's sitting with Laura in your team is focusing on tobacco and alcohol, and I know that's really helped and augmented some of the activity from that team. So there was some quite high profile work done. I think it was this year. I'm losing track. I think it was just earlier this year.
confirm that to you.
Yeah, I'm not thinking of that one then. There was some work done too, and I think one establishment was closed down for selling illegal and illicit tobacco. And I know the team did a huge amount of work on that. Also looking at illicit vapes, because that's the other thing that the Trading Standards team are telling me, that they've got tank sizes. They're supposed to give certain amount of puffs. I mean, it's a whole new world, the vaping stuff. But if we can't safely say to smokers, switch from this awful product, which we know will kill you prematurely, that's definitely going to happen, and switch to this other product, we need to make sure that it's compliant and it's safe for them to do so. So training standards are really doing a lot of work on that, because all of that just undermines the illicit market, kind of undermines any messaging that we give. Oh.
Yes, Pam. Yeah.
Morning, Pam Travers from CNTW. Just to let you know, we've been doing some further work with people with serious mental health problems, looking at the use of vapes that we supply, noting the different quality of vapes that are around, and the number of illegal supply, should I say, that's going on at the moment. So we're looking at how we can utilise vaping within inpatients and a wider scoping, and St George's Park is going to take the first pilot of that. Okay. So I don't know if that's something that you might be interested in, to see what kind of commitment we get from the service users around using vapes on a constant, rather than moving backwards and forwards, because that's what we note, is the move backwards and forwards between cigarettes and vapes. So just something that we're doing.
That'll be great to hear about. Kerry Apperdaly is linked in with us, and Sally. So I'm sure they'll be telling us about that next week, the next partnership. But thank you.
Any other questions to Kerry? In that case, I have one small question. Is there a tobacco control plan at the moment, nationwide tobacco control plan? Because I am to write to the Secretary of State asking
yes.
for a new
Yes.
tobacco control plan. I just want to know.
Yeah, but it's expired, and there's the ambition of which was announced to go for a smoke-free 2030, which is essentially 5% smoking prevalence. That ambition kind of sort of runs out as well, so that it's all expired. So yes, I mean, you don't really need to say new. You just need to say there needs to be a national ambition from 2023.
Yes.
And like I said, there's some really radical stuff in the Khan review, you know, such as increasing the legal age for smoking year on year until nobody can, which is really quite radical when you think about it. But then again, if you'd said to us, you know, if you'd said to me at the beginning of my career, I always like Wendy says about my passion, it's because I've been doing it for so long. But if you'd said to me at the beginning, in the 90s when I started doing this, that we would have smoke-free public places, and, you know, at that time we were all sitting on the aeroplane or on the bus and everyone was smoking, and it was radical. And again, it was public protection, environmental health staff who pushed for smoke-free legislation. We wouldn't have believed it, and it's been one of the major public health interventions ever. So yeah, I think it doesn't really matter what the national ambition is, I think now. There just needs to be one that gives us the mandate to act locally.
Thank you. So if there are no other questions, then I think on behalf of the board, may say we recommend all 3 points listed out here. And I also let's express my strong support on behalf of the committee for all the work you do. In fact, I think in the past decades, we have made a substantial progress in controlling tobacco, actually. Because, well, in the 80s and 90s, when I came as a student, you can smoke anywhere if there is no smoking sign. Now it's the other way around. So that's a big achievement towards health and well-being. So thank you very much for all you do. The committee, our board, you know, supports everything you do. Thank you. Thank you, Kerry. Thank you. Okay, moving on to the next item, Safe Haven. A presentation by Pam Travers.
Morning, everybody. So I'm Pam Travers from CNTW and the Group Director for North Locality. Jane Walker was going to be with me today, but unfortunately she's not very well, so she's not here. So I'll do this one by myself. So I'm here to move to the next slide, thank you. I'm here to talk about a Safe Haven development. So this is just an update on a new development that we have in Northumberland. So we were able to access £300,000 for capital monies from a emergency acute care bid that we did. So we've done that bid across a number of localities, including Northumberland, North Tyneside and Newcastle. And from that monies, we've been able to identify the 300,000 for Northumberland. You may hear safe havens or you may hear crisis cafes. They're one and the same. They can look very different, and there are a number already established all over the country. We don't really have many in this area. We have a couple in Cumbria, but not many over in the northeast area. The service that we're looking to establish, we're designing with those with lived experience. So we've already started the communications and gathering the information from those with lived experience about what they would like to see as a safe haven. I'll go on and talk a bit about what a safe haven is in the next slide. For capital monies, and I just need to say that we only got these capital monies about 2 months ago, and I have to say that we've a small group of us working really well together from a number of agencies, and we've already been able to identify some accommodation in Ashington. We're in the process of making sure that that's right and looking at leases and what we need to do and what we need to change in the accommodation. But we have looked at deprivation levels, and we've looked at population as well, because we need to set a safe haven up as an accommodation with somewhere where we have a good population. We have talked about how we can do digital and virtual options as well, and that's very much on the agenda going forward. We looked at who would run the safe havens. For all I'm here from CNTW, I'm representative of the group rather than anything else. It's very much about who's best to run a safe haven, and we believe that it will be the third sector that will be best. There are a number of providers who already work in that crisis pathway or offer different alternatives that will be really well suited to deliver this kind of working. But what we want to ensure is that we work together and we work with whoever the provider is to make sure that we've scaffolded that provider and make sure that those individuals are safe. Thank you. So we're looking to provide a welcoming, non-clinical environment to support people who are experiencing psychological distress. So we're looking at preventative as well as anybody who may be in crisis that actually could access further crisis support through this facility. This facility would work on an evening, so when everybody else quite often isn't around. So they usually work between 5, 6 o'clock at night until 12, 1 o'clock in the morning, offering that open door for individuals. As I say, we're developing the model at the moment and how people will access that service. But what we're keen to do is make sure that as we go forward, we've got more partners around the table with us, that we want to make sure that anybody across Northumberland who needs this service or any of the parts of the crisis pathway that are in place actually have access to that. So it's a great opportunity for us as well to start advertising what else is out there that people can access, as well as just the new development. We will have trained staff to support the individuals, and we'll be promoting recovery. A lot of individuals who are in crisis because of social situations. They may be carers that are struggling. There may be individuals who are going through separations. There may be individuals who don't have the financial availability that they did previously. So it's also about social support. It's about isolation. It's also about like simple things like helping people to fill forms in when they're really struggling, or helping people to access legal support. So the key is to promote recovery away from secondary care and acute mental health, but also we are looking as part of the bid, we said that we would reduce the number of individuals presenting at A&E because that's one of the key targets. And again, we feel that working with, as we've already got relationships in Northumbria, that actually we could offer more than we do currently with this service. And when I say we, I just need to keep saying it's not CNTW, it's all of us. So we are looking at emotional support. We're looking at having an environment that's a non-medicalised environment. So we're looking at an environment that's comfortable and welcoming to individuals, that people feel comfortable to drop in and have those conversations, that maybe they won't go and have conversations with other individuals. So that's what we're looking at, and that real non-medicalised approach. Thank you. So just the next steps that we're on. As I say, we're only 2 months in, I would say, about. Fabulous that we've found somewhere. We're now looking at dividing the staffing model and the model for delivery of care that will be done with those with a lived experience, as well as our own services that we've got involved currently. We've got the physical building, so we're just doing the work around that to make sure that that's the right building, that we can do all the leases and we can get everything that we need in that building. The other thing is to look at what we're going to spend the capital monies on, so it will need some alterations and some developments, and again we want to provide an environment that's safe and comfortable. We have weekly meetings. Wendy's very kindly, I think, would say, has joined the meeting, which is really helpful. And the meetings are very focused on what we achieve in that week. We're very business focused at the moment and just task and finish really focused. These will grow and they develop as we develop the model. As I say, we're keen for other individuals to join us in that meeting. We have brought in the police to other meetings and we'll be asking those to join us as well, so that they can also utilise the facility for anybody that they may see. And then there's the engagement and feedback from service users. So as we set anything up, we'll be looking for feedback from those service users. Thank you.
Yes, thank you very much, Pam. It's a truly uplifting story. Nice to hear that. Are there any questions? Yes, starting with Wendy. I think it's your project, your initiative.
Thank you very much, Chair. Pam, I don't need to tell you how thrilled and excited I am about this. This is just wonderful to know that our residents, if they're feeling low, they can go there after hours and at weekends. It's just so exciting for me to know that we've got one. And the goal is we have more scattered around the county. Just can't thank CNTW and partners. Can't thank everyone enough. It's just amazing. Thank you.
Thank you. Yeah, is there anything else you want to add to?
No.
Thank you.
I have to thank the partners as
Margaret,
well.
Yeah.
Hi again. I think it's brilliant. I'm Maggie Bailey from the Third Sector Health and Wellbeing Network. And fantastic that we've got this money for the capital side, the accommodation. However, we need the revenue funding. One of the biggest problems we've got in getting people to the centre is transport, especially at weekends and evenings. And whether these services are needed, we need people who are presenting either at NSEC or other charitable organisations throughout the Northumberland area. There's no transport. We really need revenue funding to add to this project for transport to get people to this Ashington site and the other sites that will come. So is there any provision for seeking revenue funding for the ongoing project costs?
We are currently discussing the revenue funding because there'll be staffing costs and ongoing cost for lease as well and things like that. So we're in discussion with that with the ICB to see how we can secure those fundings. I think though we need to think about the wider offer as well. So out of hours, there is a wider offer around crisis, and I think that's one of the things that is going forward. I would like us to start promoting the whole pathway that's there, because we have other providers who will go out and see individuals if somebody is very distressed. So it's not just always about people accessing, it's also what else we can offer on top of that. I really do think there's something virtual that we need to think about across Northumberland, about how we operate across such a large county, and make sure that we support those individuals who need it.
Any more? Judge, please do.
Thank you. Excellent. Just wondering about the catchment area and whether this is something which is just allocated to that locality to start with, or whether it would be available to all residents depending on transport, etc. So it was just kind of your ambition of your first one is who is your catchment area?
We've actually not established and said we've got a catchment area at the moment. The key thing was to make sure that when we were developing the first one, we had a building that was suitable, safe for everybody to utilise, but also a building that was within a well-populated area, and areas that we know that we see a number of individuals from already, and are in touch with services. So we haven't actually stipulated that outside a catchment area, outside Ashington, you can't come at the moment. And I'm kind of speaking for the group now, really. I think that's one of the ones we'll take back and discuss. But I think, you know, the more people, the merrier. I'm a bit like, the much you can offer support, the much better it is, really.
Okay. Any other? Okay, I just wanted to ask a related question. So having learned from the experience, do you think we should scale it up so we can make a recommendation to the cabinet to explore the ways of scaling it up, like, you know, one in Blythe or something like that?
Absolutely.
Yeah.
We use one in Lyme and like one in Berwick and
Yes,
one in Hexham.
sure.
Yes,
Yeah.
yeah. I mean, that's the plan.
Mm.
Yes.
So what is the project timeline here, Wendy?
When do you think it will be open, the one in Ashington, Pam?
So we are aiming really for beginning of next year, financial year.
Okay.
I think it's the challenge will be getting the works done, the building works. I think other than that, we're probably quite good to go really on a lot of other areas. But it is just that it's getting the building works done. We've had a very kind offer from Mental Health Concern. They've already got a builder they're using, so they're very kindly offered to lead on quite a lot of that work. But it will be dependent. And at the same time, we're setting up another one in Newcastle, and also one in North Tyneside. So we're looking hopefully to get them all going at a similar time.
Is this the first of its kind in the Northeast, Wendy? Yeah, so
it's
it's
our first safe haven.
Yeah,
Yes.
yeah.
And let's hope for many more.
All right, okay.
I do love safe haven. I think that sounds really comforting. Yeah.
So it's a grand success story. Thank you. Thank you very much. Yeah. All right, the next item, verbal update from Dr. Alistair Blair.
Chair, we've got some slides. I'm happy to do a verbal update or just to use a couple of slides if you prefer, whichever you'd like.
Whichever is most comfortable to you.
It might be worth sharing a couple of the slides just because I think one or two of the slides might give some of the flavour.
Yeah, so this is about performance details and the winter plans because it's the follow-up of what some people raised in the last meeting, how the NHS and GPs are coping up with this one. So that's...
I'm talking about Northumbria Trust. I'm not talking about general practice.
Okay,
that wasn't
right.
asked to, and that's probably not my remit either.
Yeah,
Do you want me just to do it from here?
Yeah.
Next slide. Next slide. My colleague Simon Eaton, who's one of our physicians and business unit director for medicine, is going to talk a bit about the winter plan because he's living and breathing that continuously. So I'm going to keep my bit quiet and brief. This is October's data. November's will be ready probably today or tomorrow, so apologies I can't give you November's. But this just to give you a flavour of how the trust is performing. So if we look at ambulance handover delays, which is something that is very prevalent in the media, we had 114 longer than an hour in October. If we look at A&E attendances, 90% were seen and discharged within a 4-hour window. They were either seen or discharged or seen and admitted, which is the best performance in the country. Not where we want it to be. The national target is 95, but still not probably as low as the national perceptions are. If we look at the wait for people to get scans and relevant diagnostics, which are coming from primary care or consultant colleagues when they've been issued, the target would be 99%. We're about 97% within 6 weeks. If we look at people who are receiving their kind of, from the moment they're referred to their definitive operation or anything within 18 weeks, it's about 82%. There are one or two specialities, particularly urology, which are high volume and massive pressures under, that skew those figures, and a lot of specialities are running very comfortably so that people are seen and receive their operation within 18 weeks, including people like, hips and knees, which are something that's often talked about in the media. There's nobody in Northumbria we would want to be waiting over a year. At the moment, there are 26 patients. We are looking at those individually, and some of those are clinically complex and they need specific bits, so there will be clinical reasons for the delays, but we are aiming to make sure that there are nobody waiting long for any procedure. And then lastly, looking at cancer, we've got just about 95% of people who have got suspected cancer coming from primary care are seen within 2 weeks. They're getting their diagnostics above the national threshold. There are some treatment delays. Again, some of that is related to urology services, which again is a high volume specialty. Some of this is actually, we're noticing that post-COVID, there are some very complicated patients coming through where it is not necessarily clear what the best treatment options are for them. And rather than making a rushed decision, some of them are needing additional diagnostics, additional bits to make sure that the treatment they receive is the right treatment. So there are clearly some gaps there within that 62 day. Next, I think this is just to show the pressures from an accident and emergency attendants. You can see the kind of, if we go from left to right, so it starts in January 2000, and you can see that the dip that was there with the first wave of COVID, you can actually see now that actually at the present time, A&E attendance are now probably at an all-time high, and I think that reflects pressures in the system. I can skip the next slide if that's possible, and next slide again, and this just gives you an idea of the performance for Northumbria on a kind of national basis. This is A&E. The national standard is 95%, so we're not achieving the national standard, but we are the highest performing trust in the country from that point of view, and you can see the range. And next slide again. Diagnostics, again, we're doing well on a national basis. You can see that we are above the pre-COVID, the long extended standard for that, but in diagnostics are in the top 10 in the country in terms of speed. And next slide, please. And this is the referral to you being seen and treated, where performance is, again, the best in the country. So I wouldn't say things are perfect by any stretch, but I would say we're doing very well compared with our peers, but that is not a case of resting on our laurels. We want to absolutely improve on where we are, because although those are good, it's from a sliding national basis, and we would always seek to actually regain where the situation was 2 years, 3 years ago. But it's just to reassure people that these are slides that come through to the board on a very regular basis. We're absolutely monitoring this on a weekly basis, and B, that actually for our residents in Northumberland, they're actually getting a much better deal than a lot of the rest of the NHS. We would like the rest of the NHS to improve, but we have still got room to improve too. I'll close my slides there and then hand over to Simon on the winter plan, if that's okay. Then we could probably take questions together at the end.
Okay, so my name is Simon. Thank you for welcoming me here. I'm one of the medical consultants, and I'm the business unit director for medicine emergency care. So if we can switch to the winter slide. Sorry, we're not more linked up. So just the next slide, you've already seen, so that's the same picture as Alistair's shown around A&E attendances. I'd started just at the beginning of this slide in my role as business unit director. We thought that was a busy winter before we went into COVID, and just in terms of, it's just showing us that the overall numbers of people in the system are higher. The other thing just to pick out from that is we just didn't see a summer. Usually there's a quieter period. We may well see a winter on top of this, but we certainly didn't see any reprieve over this last 12-month period. So again, that just means that our workforce is really stretched at the moment and are all very tired. So we've got a number of concerns. I won't go through all those sort of things, but it's very complex what's going on. But we are absolutely wanting to make sure that we're managing this volume of people who need the care that they need. So just for the next slide. I've not gone through any of these things in detail, but would be very happy to either today or at another time if people have got particular interests. But we have got a winter plan that considers all aspects of the overall system. And from an organisational point of view, myself, Elliot Sykes, who's my counterpart in surgery, Elaine Henderson, and also actually Christine Patton, 2 senior nurses, have been asked to free up our job plans essentially to take an oversight role on flow and making sure that the system is working over this coming winter, again as a symbol of organisational commitment to this really. But our key message with any plan is that it's only as good as where we get to today and where we get to tomorrow. So responsiveness and agility is absolutely what we're going to need to be doing over the next 6 months and ongoing. Next slide. So really, winter isn't new, and so there's some very well-rehearsed plans and pressures across the system. Number one thing is thinking about our workforce. As I say, it's really been quite relentless over recent years. Everyone will recognise that. And so we are actively watching that, and we're particularly trying to triangulate sickness, absence, staff experience, vacancies and various other things to try and understand where the particular pressure points are and then working to address those. We're not just about emergency care, we're also about elective delivery, and we need to deliver both of those. Part of our structure, particularly with NSEC as the emergency hub, if you like, and the base sites, allows us to separate out that work, which is a huge benefit to us over places in the same building, if you like, where one will often overlap into another. But there's sometimes pressures in both of those. Obviously, we've got the pressures that everyone knows about with the viral illnesses that are around and all the various other things that are happening. But our primary aim really is to continue to deliver the high-quality care that Alistair's already assured you about, and maintain safety in that, and particularly the points of most risk, I guess. One is the ambulance corridor, particularly if the ambulance can't get back out to see the next person. Any one of us could be in that road traffic accident or that heart attack or stroke that needs the next ambulance. If they are waiting at a hospital to drop a patient off, that's a big problem, and that's a big issue nationally, obviously. But we've also got issues of risk around people in waiting rooms waiting for care, ensuring we've got that flow, ensuring we're effectively discharging people from hospital, and also the risks of actually being in hospital. There's increased risks of falls, confusion, catching infections from each other. So if we're doing this right and we're keeping people in hospital when they need to be in and getting them out when they don't need to be in, then we are balancing that risk as best as possible. Next slide. Just to kind of, again, focus on we're doing a lot of work to try and look after our staff, both their well-being in work, but actually how we're supporting them generally as well, because there's a lot of pressures, obviously, outside of work as well. Next slide. And one thing I did just want to focus on is, obviously, we can only do this in partnership with you guys and with everyone else. There's a lot of work going on to stay linked up and stay working together. And we've got a specific pilot with the ambulance service at the moment where some of the emergency care consultants are linking into what they call the stack, the list of people waiting for ambulances, and to see if we can help them deliver that in a different way. But potentially, actually, you don't need an ambulance, there's no way of dealing with this, or the ambulance could take you to the urgent treatment centre if that's more appropriate, or downgrading the urgency, etc. So that's just started, but we're quite excited about the potential of that. Obviously, there are close links between GPs and the primary care networks and primary and community care generally, which we're trying to nurture, and Alistair's a key part of that. And various other things that are ongoing and happening to try and stay linked up and work with each other to make sure that we are sharing the risks kind of regionally as well. Final slide, please. That's it, thank you.
Thank you both. Thank you. Are there any questions to Alistair and Simon? Yes.
Hi, again, Maggie Bailey, but I'm also Chief Executive of Coping with Cancer. And we are having high demand, ever increasing, for our emotional and mental health counselling services. And I just wanted to ask and clarify, when you say nearly 30% of people are outside the 62 treatment day wait for treatment, how many people, my guess is that's hundreds in Northumberland, how many people does that percentage actually represent from Northumberland?
I don't know the numeric number off the top of my head. I can get it for you, but I don't know. And a lot of those might be waiting. It's an arbitrary cut-off, so some people may be a week or two later. This is not that they're waiting a long time. And quite a lot of them, it's an informed decision because actually they want to look at all of the treatment options available to them. So it's not necessarily that there is a delay, that they actually sometimes are saying, well, actually, I want to look at these options. You also have people who are saying, I want to go on a holiday before I start my chemo. And being honest, if it is not going to be critical, I would encourage people to do that holiday rather than cancel things when they're then going to spend the next 3 months feeling less than brilliant. So there are a variety of bits, but within that, it's still not where we want to be. But I can get figures through for the chair.
Thank you.
Thank you very much. Are there any questions to both of them? I have just one simple question. You know, it's very nice to see Northumbria Health Trust is ahead of many other trusts in the, you put the top 10. So how is the picture generally like, the trend? I mean, is it so dynamic? Can we, at some time one health trust is top and the other time some other things are, or is it generally a static one so we can derive some pleasures or information out of this?
I think the trends are relatively stable.
Yeah.
So I would have said if I looked at the top 10 12 months ago, for most of those areas, you'd have found 8 out of the 10 trusts would still be in the top 10. Mm-hmm. I think it's fair to say, on average, on aggregate, NHS performance is decreasing. Probably not necessarily to everybody in the press and the media are always quoting the worst case scenario, and I suppose my point of coming today is that that's not necessarily the local experience, but there are clearly within that people who aren't being seen as quickly as possible. So I think it answers your question. Relative stability, it's not that 1 month, it's not like the top 10 of the top of the pops or anything like that where, you rise and fall. It's static. But I would say that the aggregate position is of an NHS which is not performing as well as it did on aggregate probably 3 years ago.
Thank you.
The other thing, just to add to that, if it's okay, is that actually Northumbria has been consistently at the top of those things. That's a very consistent thing. So we've not just turned up on a good week and shared our data. Actually, that our performance has consistently been at that kind of level. It is lower than previously it's been actually in numerical terms, but in terms of the league tables, it's the same.
Okay. Yes, Jane.
Hi, and thank you very much, Alistair and Simon. I say, from the primary care point of view, I would like to point out to the board that from the work I do sort of with my compatriots across the country, we are incredibly lucky in Northumberland. We always only see our own point of view, and the media will encourage us to find, as Alistair says, the worst case scenario. But I think we ought to congratulate all partners here that we do have an incredibly good, well-performing trust, and also that they are very collaborative and have been for many years, and that we ought to do, actually say thank you, but also realise what a good position we're in. Okay, it's not perfect, but we are in an incredibly good position. And some of the stories I hear from other parts of the country about how the systems are not working just throw us into very stark relief of how lucky we are. Thank you.
Thank you very much. That is really pleasing to hear. Yes, please. David, Health Watch,
Thank you. I very much appreciate the information provided from the Hospital Trust, but might there be similar presentations in the future within the work programme for ambulance service, primary care, and perhaps even social care, difficult though that may be, just so the board is fully informed about all aspects of health and social care?
Yes.
Thanks, David. The System Transformation Board, which I think you come to, we do see all of those elements of the information there to get the assurance about how our system is working. I think it's a good question about how much of that information and how the two boards relate to each other. So at times, perhaps some information could come back up the way, but we want to avoid duplicating everything. So in some respects, the Health and Wellbeing Board needs to seek assurance from the System Transformation Board that we are looking at all that data and bringing any issues back here. But it's a good point. So I think if there are specific things that people wish to bring here at times for this audience, we can bring them. And that's not a problem at all.
Yeah, it's not for any regular presentation. It's just as and when appropriate, just to have a fuller picture of what is happening in the ambulance service, which is again high profile within the communities.
Yeah, point taken. Yes. Are there any other questions? Thank you. So in that case, thank you very much, Alistair. Okay, so we move on to item number 7, presentation by Emma. You are doing the presentation?
Yes.
Instead of Maureen, yeah. It's on Northumberland Communities Together.
So yes, thanks for having me. I think I was invited based on the last meeting where there was an ask for an update on the work of Northumberland Communities Together. But when we chatted about it, we also thought it would be helpful to cover off the corporate touch points that underpin the work of Northumberland Communities Together. And then, of course, the current cost of living and our response to the situation and the poverty and hardship plan that's been led through public health and delivered in partnership with Northumberland Communities Together and others. This is a really busy slide, and I apologise, a lot of my slides are very wordy, but I'll jump through them, but it's an important one. It's one of Paul Brooks's, and it shows the level of partnership and collaboration and involvement that we've got. And there's a word that my colleague Kerry used earlier on, which is radical. And I think there is something about noting the leadership and the opportunity to do a lot of this work that we've accelerated over the last couple of years, culminating obviously in the inequalities plan and all this talk of partnership and working together to get core services right and to pool resources together differently. So that is a helpful slide, and I would ask that when it comes out that you do have a little look at it and see what the detail of that working is, but we'll dance across it anyway. So Northumberland Communities Together, you'll know the core support offer. It did come from the work of the Empowering Communities project, which ran before its time, and a lot of asset-based working before that. But basically supporting residents with the most appropriate and effective support. There's some big hitters in there that we're all very familiar with, the Household Support Fund and the nets that we've had as our welfare assistance offer in Northumberland. And more latterly, working so closely with Citizens Advice for an energy pathway that's become increasingly pertinent. During the pandemic, it was about topping up and so on, but it's become obviously a bit of a pressure here, and that's about making sure that people can access emergency credit on multiple different kinds of meters and so on, but also some prevention strands on top of that. The funding for the free school meal payments that was set about in partnership with schools, to make sure that families had choice. Again, complex in Northumberland because we don't have all the major supermarkets local and so on, and you know, just acknowledging our geography is so important. And of course the targeted expansion of our community-led HAF programme. I've put the investments that are sitting alongside them. But I think one of the things that's most important of Northumberland Communities Together is that a lot of the delivery is not coming from the council. There's a lot of delivery in partnership, in kind, and so on. And that's about moving resource around a bit differently, which we'll come on to talk about. But also Northumberland Communities Together is very present in the communities. You'll know our warm spaces and places and guaranteed a warm welcome. People being warm and connected, you know, looking at it, as well as staying warm, loneliness and so on. And it is about our community hubs, which are fabulous, which has got community-led programming, but it's also about what we're seeing is a new emerging noise and leadership, which is quite exciting. Hyper-local places coming forward saying, well, we're open on a Thursday, we can put the kettle on, and that kind of leads me a little bit towards safe havens and a graduated approach and these sort, how does that all tie together? And the locality coordinators who've been with us for a long time now, mapping and getting to know people, are really in about that work and listening to who's coming through the door and what's going on. You see, there's been some interesting coverage on the news about warm banks and warm spaces, and it's a listening exercise and how we're doing things differently with that. Our pop-up programs and take-up campaigns, really important around. A good example of that would be pension credit. You may not know, but to sign up for pension credit, you're eligible for cost of living payment. Using data, we know where we have an under take-up of that. So our pop-up programs in partnership with our VCSE colleagues and our warm spaces, a bit of awareness raising that we can monitor that uptake and making a big difference without it coming from grants and so on. It is about entitlement. Our teaching and learning opportunities, anybody who's been particularly into our flagship hub in Cramlington will know that we've got youngsters who came in with additional needs or perhaps whose school didn't go so fabulously for, and some of them are now in apprenticeships here in County Hall, and others have gone on to employment elsewhere, which is fabulous. And our leaning in to work, I think, as I was making notes and listening to colleagues speak, and it is about connecting and joining the dots. And prior to this meeting, Graham Binning and I were having a chat that the role of that conduit and that vehicle communication, and NCT really picks that up, that it's quite fluid in communities to understand what's going on across all the sectors, because that's important. So the corporate touch points, you'll see actually the Thriving Together branding is on the Inequalities Plan commitment that's been signed this morning. Our VCSE support contract, which is the contract that it facilitates the touch points with our community sector, was reviewed at the very start of the pandemic, actually, to look at what all stakeholders wanted, including, most importantly, really, our community sector, what would be helpful and where were we going and how did we want to invest in that. And it came through loud and clear that that is a platform to facilitate that cross-sector working. And I keep saying cross-sector because it's important that we're in it together in setting the brief and pulling the work and also understanding the resource. We talk about duplication. And going forward, thinking about the way investment is shifting, this is ever more important. So that contract was awarded to Citizens Advice, and it does to connect to the traditional infrastructure support, but it's about building those relationships and being able to hear even the quietest voice, building those partnerships and collaboration and enabling that work. It's not so simple for a VCSE organisation, a warm space or so on, to come to a meeting like this for a morning is a morning without service if you've only got 2 staff and so on and so forth. So it's about understanding all of that detail and also enabling that new investment, which we'll come on to talk about a little bit. So where we are with that is that we've got quite an extensive network, including pertinent to this group, the VCSE Task Force, which is working directly with Jill O'Neill around the inequalities to see how does our voluntary sector come together, and it's an open meeting, so anybody who's watching or listening who's interested in that, to pull together and deliver the inequalities plan. Quite an exciting and lively meeting, had its inaugural meeting just last week. Seeing increasingly best fit representation at the strategic table across the system, and that includes at a national level, which we'll touch on as well, and has secured more than the value of the contract. I mean, we're 16 months in and we're at £700,000 has been brought in for cross-sector working. That is not a small amount of money for this kind of work that we're really reaching towards. And the handling of the investment for that from the NHS, you mentioned the well-being of staff, that's sitting with Thriving Together, who are programming some of our VCSE colleagues to do various bits of well-being work with staff from the Trust and others over the winter. It's how are we joining up and making resource work for Northumberland in all that means. So working together with North of Tyne as well and the Integrated Care Board, and really quite present. This is a very quick model of what that looks like. I don't need to go into the detail of it. It's in, don't have me panicking if I lose my slides. And this is just going back to that funding. The model for releasing funding also moving away. How do we commission and grant a little bit differently? So looking at where funding comes in and who needs to be around that and thinking what we're trying to do with it. How do we agree the criteria? Who needs to be on the panel and where does the reporting go? And we're finding that's landing very well with national funders and also at a policy level with GoLab and others. How are you doing that? So we're testing and learning from that, and happy to come back and talk about that a little more. So just why this matters, for all of the reasons that we're here today, we're able to make those 360 decisions with resources to avoid that duplication. I just mentioned that funding, so population health management, a fund that came down through the NHS, population health management for health inequalities in that hyperlocal way. What do we want that to do, and how do we need that to work, and how do we find best value? And we've got a workshop later this month to set that criteria, to launch that in the new year so we can really make some inroads, because new money is for finding new things to do and new ways of working and for learning that we can build from. Reach and meaningful contribution. So we are influencing regional and national policy. A great example for that is our holiday activity and food programme, which is now 6 years in, but we're not long back from London, where we took a group of real lived experience, 4 young people who came down to meet with DFE, Nike and a whole load of other people to see what does the holiday activity and food programme need to do for teenagers, how does it ready them for future life and so on. And that now becomes influential in national policy, and we can do that when we pull together, because we're noisy in a good way, because we're going with solutions, not with problems. We know the problems very well. Collaboration and mobilising those bids, example, the shared prosperity funding, having the Thriving Together networks means we have a readiness to apply for funding wherever it's going to land, and it's well received. So the shared prosperity, and I'll talk about that a little bit about the VCS liaison, but Sarah McMillan came along and talked to the VCS liaison group about that, which Paul chairs, and the group then went away and had how could we be ready for when this comes out? Because of that readiness, we're successful in their bid with an exemplar bid for the employability multiplier, rather than scrambling to try and find, there's a readiness and an influence of the shaping. And community-led messaging, all of this work needs our communities, and we really need to be talking in a much more local way, and capacity is a challenge, so the more we're all on message, the more important that ever is. And I've mentioned there, we've talked about some of the challenges we've got in the communities, adult social care and so on. There's solutions there that can ease that, and that's about understanding what and how, and what do we need in place to make that happen. And I said that about the new money allowing us to try new things together. School readiness we're focusing on as part of the Levelling Up in Ashington, and there's some great bits and pieces coming out around toilet training and just even having the same messaging in the local cafe, in the family hub. And these are small things, but they actually make a big difference, and our communities are right there with us to help us deliver these objectives. Very quickly, the VCS liaison group was repurposed so that we could set the agendas together. Using Thriving Together networks, we meet with the chair a couple of weeks before. I gave the example of Sarah McMillan. The value of that is the visibility and trust. We are all working to these same ambitions. We want the best for our residents. So it's important that we're part of setting that together and having those discussions. And the work falls out of that and does deliver from that. It's quite an exciting and it's a lively meeting. I'm sure Paul would agree with that. So for the last part of it, the response to the cost of living, it was important to show that that's underpinning this work, because that's all there. And otherwise, when we talk about the numbers and the investments, what does it mean? What's it going to look like in practice? And the value that is. So it is building on that significant work that Paul Brooks and his team are doing with Northumberland Communities Together, and that Thriving Together are doing in the wider VCSE, because to be clear on that investment, that doesn't go to Thriving Together. That is distributed to the partners that we need to be working with us and alongside us to deliver what we're trying to reach. So the focus of our poverty and hardship plan is around that targeted support, making sure that's in place for coming months. Food, fuel, children and young people, of course, because they're our future, and access to advice and information. And there's a particular investment that's come from public health reserves, and you can see that, and we're looking at additional secured some of from the ICB, which is great. So continuing to effectively target what we're doing with the funding that comes down from government, like the Household Support Fund, using our data and our insights with intelligence. We can't be everywhere, so where do we need to be? We can't reach everybody, so who do we need to reach? how all of that best practice about how much an award should be. The Hug vouchers are a great example for free school meals. We needed in Northumberland that flexibility to deliver free school meal funding to children so they could spend that locally. We don't have the same supermarkets across the patch. So we need to work that and know that stuff, and also where it needs to be. So the support in place that we've covered, including the website and other bits that you'll have heard of on this, from this meeting and others. But in terms of next step, we're investing in a policy and practice lift tool, which will pull all of our data, including our revenues and benefits data, to show us where we can make a difference and where our biggest concerns are. But also remembering that we have NCT, which is a 7-day-a-week phone number for anybody, and there is something there. So if in doubt, everybody, that is a key message. Food, we know the challenges we're facing with food, and we know that that's disproportionate according to where people live and so on. So we have got a nomination to work, an allocation to work with our food providers, going back to the partnership way of working, to ensure that we've got sustained support over these coming months, and that is about good quality support. So work close with our food banks and our hot food providers and our warm welcome, warm spaces and so on, to be able to say, well, if you want to do soup on a Wednesday, we can support and facilitate that. There's also a training element around food hygiene and upskilling and different things, again tying to that strategy about safe havens and not being lonely, and how we use our libraries and all those fabulous things. So the warm spaces under that. But from that, there's also, and I know this is a big thing that Wendy's keen on too, is, the enterprisey elements around community fridges and larders and shops, which serve multiple purposes in communities. But that's not about doing to our communities. It's about understanding who's interested, who's keen, where might we need that, what might it look like, and a very locally designed model. Similarly, fuel, I mentioned our energy pathway. We've got additional investment for that. So that energy pathway will continue, where residents are supported to immediately heat their homes, with some crisis support. But then on top of that, that prevention and connection support, and through NCT, that wider, the children in the family that perhaps could go to one of our holiday camps or activities, there's a warm space nearby, or and just joining that all up a little bit more. And on top of that, we also have the warm homes on prescription, although it's an energy pathway plus, again, for collaboration, bit of discomfort with the word prescription. So actually we can just change that and get it right so everybody's comfortable. That's really important in collaboration, which is about our residents who have respiratory conditions and things where a cold home is going to really cause an additional problem to the life that they're living at the moment anyway. And how do we, using social prescribing, using Northumberland Communities Together, support a different longer term intervention that hopefully will have that avoid a negative impact, but also give a positive impact for those residents. And that is very much about working together across the system, because there's a lot of data and other bits, but everybody's leaning in and really wants to make that work. And it's quite exciting when you're in that place, because you're not carrying the responsibility yourself, you're sharing it and you know where you're going. And that's kind of what this is all about. Children and young people, anybody who works with me knows this is my passion. Children and young people, we just want it to be right for them. We want them to be enjoying their lives, to be benefiting from education and the opportunities that are around them, and this fabulous county that we live in. So on top of the other things that we've touched, we've got Healthy Start. How do we do some take-up campaigning around that? Free school meals, we're working with our revenues and benefits colleagues to make sure that that's there, as well as our schools, supporting North of Tyne with their work that they're investing around child poverty. But on top of that, through the school setting, a lot of the time the bits that are missing are the immediate hardship support. So what we've learned from Household Support Fund is just how we can use technology, mobile phone, to get cash, to get a voucher to go and buy some hygiene products and things like that, to do things a bit more dignified, a bit differently. So through one of the things we've set away immediately with this for the young people is through our school colleagues to say, if there's somebody presents and they need something connected to either eating, sleeping, playing or learning, which is learning from a model that Save the Children delivered a number of years back, let us know and we'll mobilise support to that. And we're going to use that. Now, that's not about duplicating the Household Support Fund. We've got some questions around free school meals, and some schools have got some real concerns about numbers of children who, and we need to understand that. And the only way to do that is to pull the conversation together and get doing stuff. But in the immediate term, the ask is get in touch with us, and we've got an offer there in place already that is simple and accessible, nimble and robust as well. These are important factors. So I've mentioned school uniform height. These are all the things that come through that you know, families are experiencing. But the important thing for us is that we're ready to say, yes, we can do a thing with that. Let's figure out how we move it forward. So access to advice and building community resilience, part of the investment is also to expand, and this leads to and connects to the inequalities plan, all of the asset-based working that we're doing with Cormac. So building on the Northumberland Communities Together team, with some team who will be co-located, present in our communities, again led by that business intelligence of where they're needed, rather than just drawing a line across the county and saying we'll put one here, one here, one here, and to make sure that we continue to embed those community development approaches and see the work that's going and invest that proportionately and appropriately. And Paul and his team are working on with that. And we've also set aside the additional funding there without anything around it, just because at the moment we're in such a changing world and we don't know what's there, and we want to be, my colleague Jim Brown used the term nimble, and I love that. We want to be nimble to be able to respond and support our residents using the vehicles and pathways that give us the assurance we need to know that we're spending well and properly, and it's tying to where we're going in the future as well as helping people in the moment. So that's there, but it does include that. Just how are we building a future from this moment that we're in just now? Thank you.
Thank you, Emma. It's a very informative, detailed talk. It's really useful. I think Northumberland Communities Together is becoming a good asset for the council, bringing together people, connecting them with voluntary services is a great asset. Are there any questions for Emma? Yes, please.
Thank you, Chair. And it's not really a question. It's more, wow. I mean, so much information, and we, as a council, are doing so much. And just really for anyone who doesn't know the background of Communities Together, this was started at the beginning of COVID to help our vulnerable residents, and it has just gathered apace. We're doing so much now under the banner of Communities Together. And just really, because we have the press here, I just want to bring in Liz. Universal credit in our inequalities plan, we felt that there were people entitled to universal credit, but they weren't actually claiming it. I just would appeal to anyone and to the press that if anyone thinks that, you know, or they're struggling, can they get in touch with Northumberland Communities Together? We're 7 days a week, as Emma said, and delighted to help anyone who is in a vulnerable situation. And thank you so much for your hard work, Emma.
Thanks, Wendy.
Thank you. Graham, you want to come?
More of a statement than a question, really. I'm reflecting on the recent elected members' introduction day that was held a couple of weeks ago, and the opportunities that came from that for the newish elected members in the County Council to understand what services were around them all the time, but also how they connected. And I just wonder if it's worth putting through this board that there's not only an opportunity in that for the elected members, but almost in a private session to the side of that is once the elected members have gone, or even before they come, that those key partners who are in the room fully understand what each other are there for. Because I think that's the conversation we very much had this morning, is understanding where other partners' priorities should be in our line of sight, and that we're not myopically focused on what we're here for organisationally, and we have a wider peripheral vision and understanding where things connect and join up. So.
Yeah, that's a good point, Graham. Yes, thank you. Yeah, I think NCT are really publicising lots of things among councillors as well. I think I received a bunch of cards so that I can distribute to residents. So they are doing their bit, but it's a very good point. Yes. Are there any questions, compliments? Thank you very much, Emma. So we move on. Thank you. Okay. The next item is an update, verbal update from Rachel Mitchison on place-based working. Thank you.
Hi, thank you. It's just an update really from the ICB, which is about 6 months old now, so it's still a very new organisation and still transitioning. There's two sort of partnership working elements I just wanted to update on. One is the Integrated Care Partnership, which members will be aware is the statutory element of the Integrated Care Board. And this will bring all 13 places together. And that's obviously very, very large because it's across the whole of the North East and North Cumbria. And that will meet on a sort of biannual basis. And this is very much about making sure that the Integrated Care Board is moving in the right direction in a strategic way. There will be meetings in the North. And I think a starting point for discussions was around a group that does already meet with elected members and chairs. And that was the discussion was taken to them to say, could this be the local group for that partnership working? So discussions are ongoing about whether it will include those people, maybe other people, how it will meet and how it will help inform the strategy really of the Integrated Care Board. So ongoing discussions with that. And then our place-based board, which is currently the System Transformation Board. We have been in the past really a consultative forum where partners come together and share information and talk together. This committee is going to move to becoming an ICB committee from a point of view of there'll be ICB will ultimately make the decisions, but we will make those decisions with our partners in the room. And so in order to do that, we just need to change the terms of reference. We need to just make sure that the membership is right. We might even confuse everybody and change the name just so that we're clear that what it's doing. But so that was we're actually meeting next week, and then in January we will focus in with all our partners, maybe on an individual basis to focus on the terms of reference and what everybody would like, and then hopefully we might be in shadow formation maybe February, March, and then be live and operational in April. So that's really all I wanted to say. Happy to take any questions.
Thank you. Thank you, Rachel. Thank you very much. Right, so we can move on to the ninth item by Rob Murphy. I think we had thematic updates on 3 themes last meeting, and this one is on the wider determinants thing. Thank you.
Thank you for that, Chair. I'm going to talk about the work on the wider determinants of health, and I want to bring us to a position of shared understanding about this. I'm not going to use a presentation, so I want you to listen to me, and let's have some back and forth on this one. This may sound like a start of a journey, and I'm going to be saying some things which are very depressing to have to say that this is a start of a journey. Okay. When we talk about the wider determinants of health, we are talking of looking at the spatial patterns of inequality. In other words, where people have poorer health, where people have different elements of different layers of disadvantage. Interestingly, how health inequality plays out in different places is the single most statistically clear spatial pattern of inequality out of all inequalities. Okay? I'm not saying it doesn't happen everywhere, but it happens in particular places to particular groups of people. Okay. When we talk about wider determinants of health, we're talking about how we change those patterns. Okay, and I'll give you a quick list here. Because the world of public health, however you want to call it, and the world of planning, which are my background, talks about places, actually came from the same starting point. You may have heard stories about things like how they worked out how cholera spread in the 1850s. It was through looking at patterns of poor water quality, poverty, and incidence of health. Okay. Let me be clear on one thing. When I talk about patterns of health inequality, and with all due respect to NHS colleagues, I am not talking about patterns of inequality of access to healthcare. I'm talking about spatial patterns of inequality of health, okay, in its real sense. Okay, here's a good action list. How you tackle this issue. Community engagement. Mixed tenure, affordable housing. Well-designed, good quality homes with gardens. Tackling localised health problems as an absolute priority. Having a strong local jobs offer and easy commuting. Opportunities for residents to grow their own food. Lots of green space around people. Well-connected and biodiversity-rich public parks, because the effects of biodiversity on mental well-being is really clear. Tree-lined streets. The local design of local services. Co-design. Walkable neighbourhoods. Integrated and accessible transport systems. 1892 that was written in. It's part of the Garden City movement. I find that reassuring that we understand the issues, but absolutely depressing that we've not been able to tackle this. And only this morning I was having a very vociferous debate about somebody about a similar issue whose approach was, the horse has bolted. What do we do about it? Okay. What this actually comes down to, from my perspective, is about waiting. And I don't mean waiting times. I mean waiting as in W-E-I-G-H-T. What importance we put on issues. In the past, when we talk about trips and falls, say, and you can avoid pressure on ambulances through reducing the number of trips and falls by having proper designed houses, okay, and rails, etc. But when you try and upstream interventions, rather than allowing the problems to manifest downstream and be picked up by the NHS in terms of having to treat those problems, there's often a huge commercial and ideological pushback to that argument, because there's always something else. There's always another priority, you know. Unambiguous evidence shows that making the wrong decisions and downstreaming those costs is absolutely a clear issue. Okay, right. I don't just talk about problems, and in my role as the wider determinants of health lead and some of this working, I want to be clear about what we are actually going to do. Okay, so we've got some initial actions which are immediate ones, and that's about tackling fuel poverty. I can talk about some of the things we're doing about that. Support for people to live independently in the right housing. This is a key one. Making sure that people with health issues have the route into employment normalised compared with the rest of the population. And local transport policy with proper flexible options for everyone, particularly in rural areas, but not exclusively from rural areas. Okay. I know that those 4 actions are actually some of those same actions I talked about from 1892, in effect. And this is why I have started this presentation off as saying this is really a start of a journey. It's not the start of the journey, because we've been trying to tackle this for a long time, but I think it's the start of a journey with this new way of working together with the ICB and the partners around this table. So hopefully, when we talk about putting the right weight on issues, this type of group is a really important way of doing that. Okay, it's the same argument of the other parallel presentation to this is when I got on climate change. I studied that in the early 80s, and everything we know now, everything we are saying about it now, we were saying about it then, but it's become mainstreamed. And the public have got buy-in to this, and politicians. It's got political resonance. My plea to this work on the wider determinants of health, rather than treating the implications of poor health, is to have this sort of debate properly mainstreamed in the same way we've got with climate change. I could continue to go on, but the other thing I'll point out, and somebody mentioned this about the smoking issue, about change, and people were coming up with some great examples about how in the 1980s you went into pubs and they were really smoky, and you wouldn't have ever thought of where we are now. The other example I'll give you is try and think about the debate about wearing seat belts. That started off as a complete debate about you wore seat belts because you had to. Ask yourself now this. If you get in your car and you realise you haven't put your seatbelt on, you feel a sense of, unease about it. That's because that issue's become mainstreamed. Okay. These issues take time, and I know I said we started off thinking about this in 1892, but there are some great connections starting. Myself and the fire service, not natural bedfellows, you think, town planning and the fire service, but actually, when we speak, we may use a subtle difference in language. Like you talk about tackling vulnerability, about tackling vulnerable communities and helping them. I talk about robust communities. They are flips of the same coin. Okay, I'll finish on that point and I'll take questions.
Thank you very much. Thank you. It's an interesting presentation or talk. Are there any questions? Yes, Jane.
Thanks very much, Rob. And yes, I totally agree that the concepts are nothing new, and we've all been working there. But so my question for this, in this forum, is how then do we influence the activities of ourselves to address these issues? And I will just say, perhaps, my example is from a general practice point of view, is the issues raised by the type of housing we've had built across the county. And it is not, as far as I can see, diverse and allowing all the principles that you have just so eloquently put. It's high-end, expensive houses that do not address the issues that you just... And so how do we embed this?
And I think there are two fundamental answers to that question. And on a point of detail, yes, I agree with you. And people in this room may have picked up on a press item last week that 60% of local authorities have no standards over adaptability in housing. In other words, having houses that have doorways wide enough for wheelchairs, level access, etc. We do here, and this is going to be my answer, okay. As a town planner, I am always guilty of over-strategising. Like, my default answer is we need a new plan, we need a new strategy to deal with this. But actually, that's the answer, okay. And my view is that for everything we do in the public sector, particularly everything we do in the council, if we are doing a new strategy on how we design houses, but say even on how we fund local schemes on X, Y, and Z, how we look at our investment in parks, how we look at our investments in libraries or services. Every time we do a piece of work like that, when we're making our minds up about a strategy, we have a line which basically says financial sort of balance on this, and you have to fill in that section on your business case. Every time we do a strategy, if we are going to be tackling this issue, we need to have a similar thinking that everything needs to be seen through the lens of inequalities testing, okay? Because it comes back to my weighting issue. There is a lot of asks on the state when it's doing things, but unless you overtly think about what is the most important, and I suggest it is tackling inequality and climate change at the moment, that are real emergencies, that we should see everything we do through that lens and not regard it as something this group are doing. Okay, so it's that thing about mainstreaming it, mainstreaming the debate into everything we do, and that's the real benefit of having a networked-based approach.
Yeah, David. Yes, please.
Thank you. Do you think that the advocates of social determinants are adequately represented on the decision-making bodies, such as integrated care boards, partnerships, and so on and so forth?
Yeah, I would say that's true in both directions, and that remember what I first started off by saying is that health inequality particularly is the thing where there is a spatial pattern of how it expresses itself. That would suggest that actually there are factors which play out differently in different places that need to be considered when you're talking about tackling health inequality. The problem I see is that there's always a risk of making this way, way too complex. Because when you're talking about a single variable issue, and this often comes out in when you use things like double-blind testing in medical research, you can do with that sort of approach and iron out all the issues. Place-based issues are social, multivariant issues, and the same answer to the same problem will not be the same in every place. So I think it's making all the strategies right, so everything we do being done properly, and it working the other way of these groups informing how other people do their work. But I agree that the wider determinants is going to be really significant in the future. I know the government has dropped the disparities white paper, but I think we do need to be looking at how we are going to tackle this across the piece. I'm being positive that this group, if we didn't have this group, I'd be saying the way of tackling this would be to have this group, which sort of answers the question and makes me feel positive for the morning. Okay.
Thank you. So, I mean, obviously we do have a Northumberland-wide inequalities plan. So, you know, you were talking about looking at everything through an inequalities lens. That is absolutely at the heart of the inequalities plan, which we're, you know, collectively working really hard to deliver at the moment. I think, David, with reference to your point about the ICB, I think we just need to be careful about extending what they can do. Actually, the NHS needs to focus on healthcare inequalities. There are things that I think there are things that the ICB can do around the wider determinants of health within, you know, the trusts as anchor organisations, within their own workforce. We just need to be careful that actually we're not trying to duplicate activity. And I think also that, you know, the ICB, the actual board, has got a Director of Public Health, a Director of Adult Social Care, a Director of Children's Services on there. And I'd like to think that they were able to, you know, adequately represent issues around the social determinants when those issues came up. Also, there's a significant amount of public health input into the Integrated Care Board as it's sort of developing its policies and strategies. So I am reasonably confident that those will be addressed in the ICB infrastructure.
Thank you. Yes, Alistair.
I'd just like to say, I think the spatial planning is probably the biggest legacy that we'll ever leave. If you think this board will be long gone, if you think of all of the NHS policies today, there will not be any semblance of them in 40 years' time. The housing environment, as we walk outside this door, won't have changed. If I look at Linemouth, the buildings are all from 1906. The planning that was there, the fact that we're not putting cycle routes into our streets as we build them now is a legacy for more than one generation. And so actually I'd say that actually this is fundamentally important as a legacy for future generations. And we get it wrong. We actually get it wrong for now. We get it wrong for tomorrow and probably the next 100 years. So it's really important.
Can I say, that's a really well-made point, and actually you've stolen, in a way, a punchline from one of my other presentations. And that punchline is, when I was having this conversation, when I was a director rather than executive director at Sheffield, my executive director, who's in charge of you know, growth and places and housing and things like this. I said this to her, and she said, yes, but you're all bloody obsessed with all the fluffy, ridiculous stuff that the real world can't, you know, afford to pay for. And she paused, and she was clearly thinking of the most ridiculous example of things that I'd asked for that she could give me. And she said, and things like cycle paths. And that was because, in her head, that should have had no weighting. And she genuinely thought that was the most superfluous bit of state tinkering you could do. But as you say, though, social prescribing will work into the future if it is easy for people to do stuff, and you do it by designing it in. You know, I don't believe there's a way of hitting people with a stick to make them do more cycling and walking. But what you do, you make it as easy as possible. And that will require, and this is my real punchline, it requires difficult decisions. And to make difficult decisions, you need the weight of evidence and strategy.
Thank you. Any other before we move on? Thank you, Rob. Thank you. It was very, and I know this, you quoted something from 1892. We have been talking so long to address health inequalities, but we are not getting there. But it's a problem that can't be solved overnight. I think we need to have a multidimensional view going across multidisciplinaries. Okay, thank you very much. Right, we move on to the 10th item, forward plan. Any comments on the forward plan we have? No comments. Thank you. Right. So we will proceed. And then, of course, there are no urgent business except to make two announcements. And at the beginning, I said 8th of December marks a milestone, two milestones, one of which is the signing of that pledge. The other one, it also marks the last meeting for our public health director, Elizabeth Morgan, and she has been with us for 6 years, and for the last 3 years she has been the public health director here, and that's also the period when we had the pressing, compulsory need for public health, that is during the COVID lockdown. So she had done a tremendous service to our council, sitting in that post. And in fact, when I became a chair sometime in April, the whole thing was new to me. I personally owe a sense of gratitude to her because I was really nervous to chair this health and well-being. So she more or less acted like my tutor, taking through various things. And one thing she told me was very comforting. Oh, you know nothing about it? Don't worry. That is the right starting point because everything is changing. Integrated care board and et cetera, et cetera. So she patiently told me what's the difference between ICB and ICP. So I owe her lots of gratitude as well. So you will be very missed, Liz, in your in our future meetings. And I really thank you for all the service you have done so far. So just to embarrass you, I think we have got some flowers for you to bid you proper farewell in your last meeting. So, oops, that's a great one. So it's pretty heavy. On all our behalf, may I present these two lists. Would anyone else like to thank Liz for her service so far? right? Okay, so,
Wendy's got
sorry,
her hand
I'm
up.
sorry, Wendy, yes, I'm sorry. I didn't see
Thank
you,
you,
I'm sorry.
thank you, Chair. I don't want to embarrass you, Liz, but I just would like to say, as portfolio holder for public health, you guided us beautifully through COVID. I just can't thank you enough for that. And just everything, really, you've just been tremendous. And I really don't want you to go, but you said you just wouldn't give in. You said you were definitely going. So that was it. Couldn't do anything about it. But thank you so much. It's been a pleasure, a real pleasure.
Thank you.
Thank
very
you.
much.
And,
On all our behalf. Oh, no, not over. This
Thank
day
you.
is full of milestone. The second milestone is not yet over. There is also another person for whom this meeting is the last one. I was told that was Pam Travers. So we have some flowers for you too, for all the services you have done in this committee. Right? Can you please come forward?
Thank you, Pam.
Now, the final item, date of next meeting, that's going to be on Thursday, 12th January, 2023. So meanwhile, I wish you all, you have a good Christmas and a Happy New Year too. Thank you very much.
Thanks, Paul.
The meeting ends.